Let's zero in on a classic MD level Viva favorite, measuring blood pressure in atrial fibrillation. This is uniquely challenging because atrial fibrillation presents an irregular heart rhythm. Because the rhythm is completely chaotic, the stroke volume and the volume of blood pumped changes with every single heartbeat. This creates a massive beat-to-beat variability. Standard automated monitors get completely confused by this randomness, which is why they frequently spit out error codes or widely inaccurate numbers. To tackle this, British and European hypertension guidelines emphasize a return to manual measurement and strict adherence to the law of averages. In any clinical or exam setting, when a patient has atrial fibrillation, you must push the automated oscillometric device aside and grab your manual sphygmomanometer, whether mercury or aneroid. Manual measurement remains the absolute gold standard here. So the question is why? Because a trained human ear can listen to the actual Korotkov sounds across multiple varying beats and mentally average out that chaotic turbulence. No basic machine algorithm can match that clinical judgment. The manual technique in atrial fibrillation requires rigorous precision. We start with the standard preparation, 5 minutes of rest, perfect cuff sizing, and the arm supported at the heart level. But here is the critical variation. You must determine the estimated systolic pressure by palpation first. Keep your fingers on the radial pulse, inflate the cuff until the pulse vanishes, and then prepare to inflate the cuff 20 to 30 millimeters above the estimated level for your auscultation phase. Now write this down in gold ink. The golden rule of deflation in atrial fibrillation. Normally, you can get away with deflating a cuff at 2 to 3 millimeters mercury per second. With atrial fibrillation, you must deflate it even slower, around 2 millimeters mercury per second, or effectively 2 millimeters mercury per heartbeat. Think about the physiology here. Because the beats are irregular and skipped, if you deflate the cuff too quickly, you will drop right past a true systolic beat during a long pause and completely miss the true systolic number. When recording, listen carefully. Record the systolic blood pressure at the first Korotkov sound that is heard consistently. Don't just catch one isolated random loud beat. Wait for the consistent tapping pattern to emerge. For the diastolic blood pressure, listen for the absolute disappearance of the Korotkov sounds marking phase 5. If these sounds continue to echo all the way down, you default to the phase 4 muffling point. Let's visualize this 4-step sequence as a summary. Step 1. Pristine preparation. Step 2. Palpating to estimate the inflation ceiling. Step 3. The key step. Slow deflation at 2 millimeters mercury per second to account for the erratic rhythm. And step 4. Pinpointing systolic blood pressure at the first consistent sound and diastolic blood pressure at phase 5. Remember, slow cuff deflation is your absolute shield against measurement errors in atrial fibrillation. Because blood pressure naturally fluctuates widely from minute to minute in an AFib patient, a single snapshot reading is practically useless. It's a random lottery ticket. To conquer this, you must take at least 3 separate manual readings, ensuring you space them 1 to 2 minutes apart. Then calculate the mathematical average of those 3 sessions. That average is the only number you can ethically and clinically trust to guide your management. Let's look at the math in action for an atrial fibrillation patient. Reading 1 gives us 142 over 86. Reading 2 drops to 136 over 82. Reading 3 ticks back up to 140 over 84. If you only took reading 1, you might over-medicate. If you only took reading 2, you might under-medicate. By calculating the mathematical average, we arrive at a highly reliable true blood pressure of 139 over 84 millimeters mercury. So what I'm trying to say is that if the readings are 142 over 86, 136 over 82 and 140 over 84, we don't just pick the lowest or the highest to fit the narrative. We combine them, average them and confidently record 139 over 84 millimeters mercury. This eliminates the noise of beat-to-beat variability and uncovers the patient's true systemic pressure. Now, what happens when the patient goes home? They can't take a manual reading themselves, and we know standard machines struggle. If home tracking is vital, we must give them 3 strict rules. First, use an upper arm cuff only. Wrist or finger monitors are wildly inaccurate in healthy patients, and they are completely disastrous in atrial fibrillation. Second, they must purchase a specialized AFib validated device such as specific models from Omron or Microlife that feature dedicated irregular heartbeat algorithms. Third, have them bring their machine to the clinic. We can run a manual test on one arm and check it against their digital machine to cross-verify its real-world accuracy. Let's consolidate this into a crisp clinical pearl for your rounds and exam defense. When an examiner asks you how to assess blood pressure in an AFib patient, your answer should be immediate. Sir, I will use the manual auscultatory method. Employ an exceptionally slow cuff deflation rate of 2 millimeters mercury per second. Take at least 3 distinct readings and average the results to eliminate beat-to-beat variability. That response shows true physiological understanding.